This is one area that is changing so quickly. I find myself changing my lecture every 2 months. Imaging of the cervical spine trauma. There are 3 objectives to this endeavor. First, we have to detect the fracture and characterize it. We have to assess stability, and stability is a nebulous term which we'll try to describe and see how we can define it radiographically, and also predict prognosis, especially when the cord is involved. And all these are done in the setting of the emergency room where everything has to be done right away or yesterday. With the least amount of diagnostic effort. You're not allowed to make mistakes, although we always make mistakes. To err is human, and at a reasonable cost. Now let's look at plain films, which we have used for a long time and have been the mainstay of trauma of the spine till about the early 90s. And it has been advertised, although I don't believe it, that with experts, you have a high sensitivity of 93%. All the new literature disproves that because we're doing more CT. With non-expert, like the rest of us, the sensitivity has always been known to be low. This is an experimental study at this bullet here by Ambari and West, and I included it here because I knew Clark West very well. He collected few residents from different levels and some faculty, so experts and non-experts, and he knew they were tested. So it's an artificial situation. Even in an artificial situation where you knew you were tested and your proper prior sensitivity to this is high, the false negative rate was 17%. The specificity also of the C-spine as detected in trauma as detected on plain films is also low. And usually it is because of inadequate studies, because most patients who are heavily traumatized are difficult to image. So what are the drawbacks of radiography? Why are people shunning away from radiography? Well, it has low sensitivity and specificity, and the cost of missing a fracture is extremely high. And they are difficult to interpret, let's face it. C-spine plain films are not easy to interpret. The other thing that is becoming very important in the emergency room, the first hour is very important in the life of the patient. And plain films are difficult to optimize the exam in the first hour. There are views that are difficult to take and need to be repeated. Most typically are the supine swimmers and the open mouth view. Now, the question now is asked that we have CT. Does radiography add anything after we have done CT? The answer to this is no. And this has been studied. The paper is there if you like to look it up. This is not the only paper, but this is the paper that is really well done. Is radiography still used? Well, we still use it quite a bit. Actually, if you come to a spine clinic, we use it all the time to follow up healing of fractures and alignment and things like that after trauma. So it's still heavily used, but in the acute stage, it's becoming rarer and rarer by the day. There's another drawback of plain films, and that is in certain patients, no matter how much you try, you're not going to get a diagnostic film. And if your patients look like ours, they all look like this when they are heavily traumatized. Okay, the flexion and extension is a relic of the past that has been used a lot, and it's an extension of the plain film. It is theorized, although not proved in the literature, that with the flexion extension, you produce stress, mechanical stress on the spine, so you can see instability and ligamentous injury better. There is no proof that this is effective in the acute phase, okay, because patients who are traumatized don't flex and extend. They usually splint, and you have to wait 10 to 14 days until the muscle spasm and pain disappears, if this is to be of any use, and I'll show you an example of that. The other thing is there was an era early in the 2000 that somebody suggested we do flexion extension on obtunded patients, which I will discuss. Never do flexion extension except on alert patients, patients who are cooperative and have no neurological deficits, because otherwise we're asking for trouble. Okay, this is a college student, was in an accident, and notice it's a good exam to some extent, shows the top of 7, which is not totally satisfactory. But our problem was in this area down here. And we looked there, it looked okay, everything looked okay. He was put in a collar and sent home. 10 days later, he came back. We did flexion extension. And this is the time when flexion extension is useful. 10 days and beyond is when it becomes useful. In the acute phase, you may never see the problem here. But notice here, there's about 3-4 millimeters anterior translation of C6 on C7. Let's describe and try to characterize what is stable and what's unstable. The concept is, from the orthopedic literature, is that a stable spine can withstand normal stresses without progressive deformity or neurological deficit. Well, this is a great concept, but as a radiologist, it doesn't help me a bit. An unstable spine is the opposite. Under normal stresses, it can lead to deformity and increased neurological deficit or both. Now, radiologically, there is no universally accepted way of defining this. There is one method that we use. You can use it if you like. It's described by a leading spine surgeon from Boston, from Harvard, actually. He presented it in '75, and many people still use it, and it's very helpful. If you see 3.5, I don't know how he can see 0.5, but if you see 3 millimeters or more of horizontal translation after trauma of one vertebra over another, I usually consider it unstable. If you see 11 degrees of angular deformity, one vertebra over another, again, you have to consider it unstable. Let's look at the status of CT, and this, I think, took the profession by storm. MDCT, no question, is the ideal way to study the traumatized C-spine, and I'll show you why. It has a sensitivity close to 100%, and a specificity, I don't know if this is taken from MDCT, but this is what is described in the literature for CT. But I think with MDCT, we're close to 100, both for sensitivity and specificity. And the nicest thing about it, it is very easy to interpret. Most residents get confident over a few months. They can call at night in doing this. Until 1994, CT was used as a problem-solving technique, whereas if you see something on plain films, you suspect something, or you cannot shoot through the shoulders, you do a CT. In 1994, Nunes stood up in the emergency society, and I was there, and we debated it, and he said, at that time there was only single slice CT. He said, guys, we're wasting our time. Let's go directly to CT. And the public did not like that. Most of them have egos that fill this room, so they tried to object it. And the man turned out to be right, especially that history helped him in that multi-slice CT came in 1998 and helped his cause. The reason why he did that is because he had data to support that. 33% of all his cases were missed on plain films. So you have a high false negative rate. And 1/3 of these, which means about 10% of all the cases, were missed serious fractures that were significant or unstable. So he was very convincing, and he worked on it, and I think he convinced everybody that CT is the way to go. And then MDCT came, and then I think, as you all feel, it is becoming the way to do it. So what are the benefits of MDCT? Well, it is an optimal screening test, because a good screening test that catches most cases has to be sensitive and specific, and MDCT is. Imaging time is very short, and boy, this is a great advantage in the emergency department. The other thing is, for a screening test to be cost effective, the prior probability of disease has to be high. That is, the number of patients that you are scanning and have the disease has to be significant. And if you scan only high-risk patients, the prior probability of disease is more than 5%. Actually, it's closer to 15%, but anything more than 5% statistically is good. And we have all the conditions then for a good screening test. So MDCT is becoming the screening test. What are the limitations? There are two very difficult limitations. One of them, it's a high radiation dose. The second one is medical cost. Okay, initial medical cost just to pay for the scan. However, when you calculate how much it takes to do a plain film with the time occupying the room, with so many specialists waiting for useless x-rays that come out that cannot be interpreted, I think CT wins out when everything is taken care of. Okay. Let's see the magnitude of it. What are we dealing with here? We all deal with it. How big it is? Well, there are 1 million people admitted to the nation's emergency departments with neck trauma problems. Okay? But only less than 1% will have major spinal injury. Are we obligated to CT all the 1 million people? The answer is no. Okay? And although it feels to me like we are pushed more and more to scan all the million people, there are ways to cut on that, but I don't know how many people are following these criteria. There is what is called risk stratification, a system that is devised by Craig Blackmore, who has a degree, both MD degree and also MPH, which is a degree in public health. So if you take the high-risk patients, and these are people who are subjected to high-energy mechanism that have focal neurological deficit related to the cervical spine, severe head trauma, and elderly patients who are more susceptible to fracture, all these patients should be studied right away with CT. The low-risk patients are those who do not have those criteria on the top there, and the prior probability of disease here is low. Okay? And these, according to Blackmore criteria, can be studied by radiography. And if you see something there that you cannot explain well or you suspect something, you can go to CT. Or if you cannot visualize the whole spine, you have to revert to CT. In my experience, there are less and less people being considered low risk. I find more and more emergency room physicians considering the majority of the people as high risk. And this is because they don't want to miss a fracture. I'm with them there, because missing a fracture is a big deal. It's usually tremendously traumatizing to everybody. Now, one area that has not been clearly settled is when do you do CT in children? In children below the age of 9, fractures of the spine are extremely rare, and they usually fracture in a predictable way. I'll be glad to discuss it further in the recess and things like that. But usually, if they are below 9, you start with plain films and then go to CT if you need to. And if you want to read about it, the reference is at the bottom. It's in your discourse. What's the role of MDCT? Well, in the emergency department, well, it took the emergency department by storm. I don't think any emergency department can survive without an MDCT. It became the workhorse of the emergency department. It is often the only test a patient will need, high-risk patient will need. We have to understand how the CT works to give the best advantage. And to get full advantage of MDCT in this situation, we have to obtain isotropic imaging. That is imaging whereby the resolution in the X, Y, and Z direction is perfect and equal. True isotropic imaging can be only obtained, now I'm saying, although I don't always do true isotropic, I do near isotropic. True isotropic imaging, you have to go below 1 millimeter, okay, sub-millimeter. But if you have a 4-detector scan, you can't go below 2 millimeter because the dose will climb up and you have to resort to other techniques like near isotropic imaging. So not all machines, keep that in mind, not all MDCT equipment is dose efficient. Some of it actually is, in fact, gives huge doses. And this is partly because of the proportion of the useful beam, which is in white here, gray, to the penumbra, which is the useless beam, which is irradiation to the patient, but without getting useful information. The ratio becomes less with the 16 and becomes even less with the 64, although I doubt that I will ever have a 64 in the emergency room. Okay, let's take a few examples to show how useful CT is, even when it is a 4-detector slice. This is an elderly lady, came into the emergency room after an accident. She and her husband was doing well. This lady had a little swelling here. The dents looked like it is a little high. And on the open mouth view, you can probably detect a little overhang here. So what's wrong with this patient? So we did 4-detector. This is what we have in the emergency room until this point, although we are trying to buy a new one. And we did 2-millimeter slices, which is fairly safe. The dose there should be very tolerable. And then we reconstructed at 0.5, which means the overlap is significant. This is overlapping is like when you have a satellite taking pictures of New York and you see Wall Street and this and that. It is because the images are overlapping. And we're doing the same thing here. So what did we see here? In the first few cuts, we saw that the C1 is occipitalized. It didn't separate from C2. This is not trauma. This is how the patient was born. Okay? So occipital, C1 fusion, if you like, congenital fusion. There are more findings on this patient. When we looked at the axial, we see what we call a 3-part Jefferson fracture. And then there's a faint calcification here that we explored a little more by looking at soft tissue windows. And obviously, this is a calcification that we sometimes see in elderly people with CPPD. So with one test, we saw 3 diseases. And I think this is great for one test. Here you see this clump of calcification posterior to the dens and the fusion of the occiput to C1. And on the axial, you saw the Jefferson fracture. This is another patient who came into the emergency room, deathly ill, actually, and the surgeons wanted to open her right away. The fellow was looking at this. He looked hard, and they were pushing him to come up with something he couldn't. I looked at it. I couldn't come up with much here. And you can see the chest. There is tension pneumothorax, multiple ribs, fluid in the chest. The mediastinum was wide. There's fluid up here. So we were really worried about a ruptured aorta here. So we did the CT quickly. Again, this is a 4-detector. So this was 2 centimeters reconstructed by 0.5 with good overlap. And notice every vertebra here from 1 to 4 has fractures. This is a Jefferson, this is a hanged man, and these are arch, and this is a transverse process. And the patient also had a ruptured aorta, which she was rushed to the operating room with. Now, finally, I want to just say a few words about how to clear the obtunded patient. And this gave me lots of headache over the last few years. The obtunded patient usually was put in a neck collar until they woke up. Sometimes they don't wake up very quickly. Sometimes if they have few drinks, they wake up the next morning. So anything that stays on the neck more than 72 hours can produce blisters, and the nurses start complaining. It becomes another problem. So a gentleman, I think he was a surgeon, his name is Davis, in 1995, came up with the idea that drove me crazy. That he said, why don't you do fluoroscopy and assist the patient with flexion and extension? The next day after this paper came out, the nurses from the intensive care surgical intensive showed up in my office and said, this is what the surgeons are telling me, let's try it. I told them, I'm not doing this. I'm not part of this. We argued back and forth, and it took time to settle this issue. At almost the same time, a gentleman by the name of Harris in the spine, and I read this journal also because I work with a large spine group, came with the same idea, except that he added to put traction first. It becomes a little safer. But you're dealing with somebody who cannot protect himself or tell you I have pain or I have weakness or I have numbness while you're manipulating that. I thought that was the most outlandish idea to do. Fortunately, Mr. Davis discovered, or Dr. Davis, discovered in 2001 that his ideas were not good, and he published another article to say, let's forget about the first idea. And at this time, CT came around, MDCT, that can do the job. And in fact, the following articles here that came later, you know, by Widder, Morris, McCoy, Hogan. This is one of the best articles here, came recently. This is from Mirvis and his group. And they said MDCT has the capability to have 100% negative predictive value for the C-spine. This is good for all of us to keep in our drawer, you know, because if you did it and you did it well, you know, it can protect you. So let's talk about the upper cervical spine, which is a difficult area to look at. And you have to know the anatomy a little bit. The alar ligaments, the tectorial membrane, which is the continuation of the posterior longitudinal ligament, the cruciform ligament or a cruciate ligament, which is 2 parts, the transverse ligament, which we all know about, and then the upper and lower part here are called anterior, superior, inferior bands. Let's take a look at the occipital condyle. And this was not diagnosed very frequently, but now that we do CT, we see it quite a bit. It's a serious injury. There are other more serious associated injuries with it. There is a coma because the brainstem is injured. Sometimes lower cranial nerve injuries are also present. There are different types, but probably the most common type that we're going to see more frequently is a type 3, which is an avulsion of the alar, one or both alar ligaments sometimes. This is a typical avulsion of the alar ligament here. And just to show you how serious this injury is by the associated injuries with it. And this patient had a tear of the aorta and severe orthopedic injuries. This is a transverse acetabular fracture, and this is both column. And both of these are very serious injuries. Let's talk a little bit about Atlanto-occipital dissociation, which is in fact a decapitation, but not a complete decapitation. But it's a serious injury. It is occasionally survivable, especially when we are dealing with children. There is disruption of both the tectorial and the alar ligaments. It could be unilateral or bilateral. We've seen it both ways. Fatal cases have contusions in the pons and the medulla and the upper cord, and sometimes even the carotid and vertebral arteries. It's more common in kids, and probably this is related to anatomy. The head is large in children, the ligaments are lax, and the joint between the occipital condyles and superior facets of C1 are fairly flat. And mechanism, nobody, you know, remembers how this happens because most of them don't survive, and those who survive can't tell you. But judging from the bruises and lacerations on the face, people think that it is probably a hyperextension with distraction. How do we diagnose it? We can, if plain films are taken, you can diagnose it on plain films. If CT is the same criteria. And it is the dens rise directly inferior to the basion, which is the inferior end of the clivus. And the distance between the basion and the tip of the dens should never exceed 12 millimeters. There is a line that we draw along the clivus called the Wackenheim's line, and it should be tangent to the tip of the dens. But all of these I will show you in examples, so, and they are in your CD. There is marked rectopharyngeal swelling for obvious reasons, and associated injuries may include an avulsion of the basion or occipital condyles or facet joint subluxations. So if you look at this, you can see the tip of the clivus, which is the basion, and the distance between here is more than 2 centimeters, and 1.2 is usually the limit. So, and there is quite a bit of soft tissue swelling here. This is the Wackenheim's line, which you draw tangent to the clivus, and it should be tangent to the tip of the dens. If it intersects the dens in any way, you should suspect this injury. Another patient with the same injury, he actually arrived alive, this patient, and you can see here the clivus. And if you make a line drawing of this and try to draw the Wackenheim's line, it intersects the dens in a big way. So this is definitely a craniocervical dissociation. This is a child who survived and left the hospital walking, but the early diagnosis was very difficult just from plain films. But you can tell this distance is increased. An MRI was done, and you can see the bleeding in this area. When T2 was done, the injury was posterior and inferior. And when he came for follow-up, everything was reconstituted, and the patient was perfectly normal. So the radiologist plays a significant role in detecting this injury early and helping people who are going to survive this to survive. Jefferson fracture, I will show a few things here because I respect Jefferson so much. He wrote his first article in 1920, and he described everything about this injury. He knew everything about it, even before CT, before even plain tomography. And it is due to axial loading and then what we call a burst fracture of C1. We diagnose it by the presence of overhang. This line and this line should align, this line and this line should align. So there's quite a bit of overhang here. The classical description was by Jefferson was that this is a 4-part fracture, but he had no CT and no tomography. So good of him that he knew that this is what the injury was. Now we know that the majority of these fractures are either 3-part, means 3 fragments, or 2 fragments. Nobody could add a word to his article until 1970. And an army surgeon looked at all his cases of Jefferson fracture and said, boy, wait a minute. Not all Jefferson fractures are equal. Some are more equal than others. And he said, those that have an overhang more than 7 millimeters, if you add the overhang from both sides, then it is unstable. And what does he mean by unstable? It means the transverse ligament is ruptured. And there is another way to do that, like you measure the instability with rheumatoid patients, and it was suggested by Oda. I'll show you both ways. So if you add X plus Y here, and it is more than 7, then the transverse ligament is disrupted, and you have to call it unstable Jefferson. Usually they fuse them from the occiput to C2. And this is an old case, but I like it because it shows why this is unstable, is because the transverse ligament is disrupted, and this is the fragment that came from here. You can detect the same thing on this view. This is a more current case, and again, look how much overhang there is here. And it is, I like to show this because it's a 2-part fracture. It's not a 3-part or 4-part like Jefferson described it. It's 2-part, but still a Jefferson. It's a burst fracture. It's unstable because the distance is wide. And the patient was fused. Now, one thing to remember is that there's a high association between burst fractures or Jefferson fractures and dense fractures. Jefferson found 40% of his cases have dense fractures. So every time you see a Jefferson fracture, look closely at the dens. There's a very high chance the dens will be fractured. Somebody repeated this study in '89, found the same thing, okay? Now, each one alone is a very forgiving fracture, but if you have the two together, there is much higher incidence of neurological deficit. So let's show you one case, and I will quit. Okay, there is a fracture here, a little bit of swelling here. No overhang, notice no overhang. So this is a stable Jefferson. The transverse fracture, the transverse ligament is okay, but the dens is broken. Let's see how it looks on CT. You see the dens broken, no overhang. And it is a Jefferson, but it is a 2-part Jefferson, and the transverse ligament is intact.